Invite Dr. Hartley back up to represent our online questioners, but we're going to have a quick question-answer panel. I again like to thank Dr. Raz and Dr. Phelps for sharing their expertise with us.
And for in-person questions, if you can, there's some microphones in the hallways or in the aisles. If you can use those, that way those people on Zoom can hear the questions. So I'll start, John. There's one that came up during your talk in the Zoom. It said, I recognize screens, and they're talking about screens like device screens, are often comforting and ways to distract or calm children on the spectrum, but do you feel like over time we're damaging their mental health further or actually worsening their long-term health with all the screen time and not finding other ways to help them calm down? The screen time with this group seems to be so much worse than even most other kids, and the data is really out there for the damage being done in the brain, especially with respect to the ability to self-regulate anxiety and mood.
Yes, I wholeheartedly agree. We as pediatricians know that screen time is not a good thing. Yes, in a lot of instances, I think with autistic kids, we are probably allowing them to have too much screen time. And I assume, I assume that it has similar detrimental effects as it does with a neurotypical child. But in some cases, it's okay in the stressful environments that we're talking about today.
Okay, here's one for Dr. Phelps. Dr. Phelps, can you please give some local resources for social skills training? The only one I know of is very expensive.
This is a really good question, and I think a really challenging one. Most schools offer some sort of social skills training. I will say that those tend to follow a looser curriculum, and so that makes it a little bit more challenging. There are some other clinics that offer a sliding scale too, and I'm happy to kind of provide those as well and chat offline if you'd like.
Okay. And here's one for Dr. Raz. Can you please talk about pathological demand avoidance? Are there specific treatment strategies?
Yeah, so this is kind of an up-and-coming diagnosis. I don't know if many of you have heard it. I believe it's coming out of the UK. Dr. Phelps, you can correct me if I'm wrong. I don't know specifically of strategies. I think there's still a lot to be understood about this diagnosis and how it fits within our neurodiverse kids, within our typical kids. So I think I don't really have a straight answer about that right now. I don't know if Dr. Phelps, if you have anything else to add. I just think it's newer, and we have to really understand what it is specifically, how to utilize that diagnosis when it is appropriate for a child, and create treatment options that would be specific to the specific needs that each child has.
Yeah, I'll quickly add to that. So pathological demand avoidance, or also fondly known as pervasive drive for autonomy, is something that is not currently considered a specific diagnosis, but rather kind of a series of behaviors or patterns that lead to someone avoiding specific demands being placed on them. And that can make it really challenging when most of our interventions are related to telling a child to do something. And so there are a lot of ways in which we can just more gently provide some sort of statement that children tend to respond a little bit better to.
Okay.
You might have already commented on this and I missed it, but maybe more specifically for Dr. Phelps, how useful when we have limited resources with our therapists is the virtual visits, especially for things like the problem-based therapy and stuff. Is that useful, especially with the younger generation and for like the families?
That's a really good question, and I think it's pretty individually based. For young children and problem-focused therapies, that tends to be a little bit more focused on the parent, and so it's a lot more parent-mediated, and parents tend to be able to engage online better than their young kids, and so sometimes that's actually very effective, and for some, more effective than trying to get their child into the clinic.
Okay, here's another one, and this could be for anyone. Do you feel the increased diagnosis of autism is in kids with Do you feel the increased diagnosis is in kids with no previous diagnosis or in kids with other neurocognitive conditions that we now recognize autism as an additional diagnosis?
Yeah, I would certainly say that that's probably part of it. I think that children who we now recognize with having a diagnosis of autism were either misdiagnosed or maybe their diagnosis is accurate, but this is an additional diagnosis that really describes some of their other qualities in a way that's really more meaningful for them. So I think that, yes, that is true in a sense of that other diagnosis may still stand and autism may also exist, or it may be a diagnosis that autism replaces.
Hi, I have a question for Dr. John.
Yeah.
I preface it by saying I'm a pediatrician now in West Virginia, but I did my training here. I'm a native Arizonan, and he was born, my son, who's also autistic, at St. Joe's. He's now 30 years old, so I'm just at a different stage in my parental journey. But I spend half my time as a pediatric hospitalist and half of it in a clinic. But the challenge for me has been in the hospital because we do not have a large enough hospital to have a dedicated pediatric emergency room, is trying to convince, regular emergency room personnel how to approach a kid who has autism, who is difficult to calm down, to treat, and not, immediately attacking them. And so my question is, do you ever go as a pediatric emergency room doctor to those types of settings and try to help educate those individuals, and how do you think that can best be accomplished?
I have not been to an adult emergency department to discuss some of those things. I would love to. I absolutely would. As far as how I would approach that is probably similar to the discussion that we had today on showing that there's real evidence that following some of these guidelines and the certain characteristics of providers and support staff that increases parent satisfaction and increases your satisfaction scores, which, unfortunately drives a lot of what we do, especially in the emergency department.
And just thank you to all three panelists. Great information. Thanks for coming.
Hey, thank you for sharing about your son.
Thank you. If I can add, I just want to say, it really goes to John's point about, approaching the child. And I think as providers, there's a lot to say about our own flexibility in the exam room, right? I think we all have kind of this idea of what the exam or the visit should look like, and just being a little bit flexible. Sometimes I do visits in the complete dark. I have my computer, obviously, so I can see what's going on my own screen, but everything else is dark, and that's totally fine because that's what's regulating that child at the time, right? Or just knowing that some things don't have to happen in the very expected way that we might have, but it'll still get done, and it's going to go a long way for the family and for that child.
Autism, needing to see a geneticist? And if so, when is it's hard to get in with geneticists in our area, but what might the proper timing be, especially in a child that doesn't have any overt, characteristics of a syndrome? Should it be done with all the autistic kids?
Thank you. Yeah, so genetic testing is standard of care for children with autism, kind of like you alluded to. And I would really recommend that in your practices, if you're comfortable ordering, the first line testing. It doesn't necessarily have to be in whole exome sequencing, whole genome, right? That gets really involved. But even doing a chromosomal microarray, doing Fragile X testing, that can be really important as the first step. And then if there is a higher index of suspicion for a genetic condition, then that will give the geneticist further information as to what's already been completed and what they would need to do. So I would say without a high suspicion of something specific, even doing a chromosomal microarray or Fragile X, or if you're comfortable with potentially even a gene panel in your clinic, could be what needs to be done, and maybe nothing even further. And certainly if there's specific conditions to be concerned about, there are testing recommendations for those. But some geneticists are offering kind of more streamlined approaches if the child does have an autism diagnosis, to kind of fast track them through the clinic, because it is a diagnosis that genetic testing is recommended for. So I hope that answered that question a little bit. Thanks.
Okay, now here's one that came in that's a little controversial. Is it true that ABA treatment has been shown very limited effectiveness in autism? So maybe all three of you can comment on that.
I'll go first since I brought it up. So that's a really good question. And it honestly sort of depends. There's a lot of evidence to suggest that it is effective depending on what your goals are. So the goals that are usually used in, or established, I guess, in ABA are things related to increasing the frequency of a preferred behavior and decreasing the frequency of less preferred behavior. ABA is founded within behavioral principles and behavioral shaping and modification. And the reason why we find efficacy in that is because that's exactly what that therapy is designed to do. I will say, though, that if this is not aligned with a family's values, or if it's not aligned with the child's ability at that time, it's unlikely to be effective. And so it needs to be in full alignment with what's happening in order for it to be effective. There's varying literature about the efficacy depending on how many hours of ABA you receive a week. And I'll also say that not every ABA clinic or provider is the same or provides quality service. And so that's going to be something that families will need to check out and make sure that they're receiving that.
Okay, here's a very practical question came in. What do you recommend for autistic children who only sleep 4 to 5 hours per night with no naps and don't have coexisting conditions? Do you recommend medications or tell parents some children require less sleep?
Well, so, I go step by step, right? Kind of like I discussed before, it's very, very common for kids to get more limited sleep, and very rarely is that only what they need, I would say, 4 to 6 hours. So I really try to talk to the family about what's going on. And at times, medication is what's needed, right? If we've really kind of exhausted all other behavioral strategies and the family's really sticking with a routine and doing all the rest of the things that we've discussed, then sometimes medications are necessary. Just kind of in my practice alone, I certainly try to avoid medications if they're not needed, right? Because behavioral strategies are really what's going to be long-lasting for that child and for the family. But sometimes you just need to do that because for a variety of reasons, the strategies aren't working.
Okay.
Hi, yeah, Dr. Phelps, thanks for that example of that child, biracial child, and the struggles that that individual had. The treatment is certainly patient and parent focused. I'm wondering and curious to know if there's a role for connecting with the school and working with the school, and particularly in this day and age with all the information we have about diversity, equity, and inclusion.
Thank you. That's a really good question. I wish that we could be here for an entire day talking about this. I think that a lot of the talk actually completely avoided school-based services because it's such a big topic. Yes, there is absolutely an opportunity to work with schools. And in fact, schools are required to consider your recommendations. They're not required to follow them. But if you're able to provide a school with kind of specific recommendations that aren't outlandish, then most schools are very accepting of those recommendations. So even if you were to say like, hey, I think that this child would benefit from social skills support and counseling at school specific to their experiences of bullying, most schools are willing to accommodate that.
I would also add, there's a lot of schools out there doing some wonderful things now. My own son's school has multiple different structured autistic classrooms within the general ed populations. And they address bullying on a regular basis and allow these kids out within the general education population as well. And I feel like I've seen the exact opposite. I've seen the changes that it's made in the gen ed patient, my other children, to be exposed to some of these other kids. And I could not be happier with the situation we're in right now.
Okay.
Can you speak to the MTHFR genetic testing necessity? Should we be doing it on our patients who can't get in with developmental pediatrics for greater than a year? And should we be considering it for just the general population?
So that actually has come up quite a bit recently. I've had these discussions with some of our geneticists about that. Currently, there was no recommendations as a standardization to do MTHFR testing. I think our understanding of the impact of that on our children with autism is still very limited. There are families that elect to do it potentially for other reasons in their own family members, and that may come up. And so those are, I think, case-by-case discussions. But then the interpretation of those test results is also important part, because not all, if there's a heterozygous result, really not expecting that to be as impactful on the child. So I think having those discussions with the families, I think there's a lot, understandably, I'm going to take a step back. In the autism world, there's a lot out there, right? There's a lot out there of what needs to be done, what needs to be tested. Families are connecting with each other, rightfully so, and families really want to do what's best for their child, right? So they're really trying to do all the research they can. So to answer your question, the current guidelines are not to do it as a standard assessment for kids with autism. And so I just have these discussions with families on a case-by-case basis in the event if something came up with a family member, but otherwise I do not.
Okay.
What's going to happen to these kids as they become adults? Who's going to provide medical care? There are programs for kids with congenital heart disease, but there's no programs for kids who are autistic. I personally keep my autistic patients forever. My oldest is 41 years. My referral patterns are different. I'll send them to an adult cardiologist or an adult nephrologist, et cetera.
Oh boy, I wish I had a good answer to that question. It's really about increasing the awareness, having these discussions. We're fortunate enough to work with the med-peds trainees in our residency program. We're certainly open to having any other family practice, internal medicine practice providers. But, there's a big focus now on transition program work, certainly in our institution in Phoenix Children's, because yes, it's very difficult for us to let these patients go because there is no developmental pediatrician in the adult world. So it's really about kind of the soft guide into the adult world and working with the families and the individuals to when they feel like they found someone that really feels like a good fit for them. But it is hard, I understand completely. We have a hard time letting go too.
Okay, and we got one more question that you can probably all answer with a yes or no, and then we're at time. So any other questions, or you're welcome to come up here and talk to the presenters individually. The last one is, are you seeing any teens who are introverted or have social anxiety wanting a diagnosis of autism?
Yes.
Yeah, I would say that, in all spheres, social media is really interesting and helps us get a lot of patients in who have just like a really strong desire to belong somewhere and belong to a community. And sometimes it means that they feel like they fit in this autistic community when in fact, from a medical perspective, that might not be true. My job is to say, whether or not you have autism from a medical perspective, my job isn't to tell you how you identify. And so if you feel like this group, fits your jam better, awesome. But from a medical perspective, you don't have autism. But those socially anxious kids definitely come through our doors.
Okay. Well, I don't want to keep you guys over, so thank you all for your time.